Maybe we got online now. Okay. Okay, maybe we can get started. Hey, Ian, will you get the door? Thank you, dear. Okay. All right. So welcome. My name is Jill Rock-Beisel. I'm the chair of the Department of Psychiatry and have the absolute privilege to introduce our guest speaker today. Welcome to Psychiatry Grand Rounds, everyone in the room. Thank you very much for being here. And also want to thank the so far 44 people online. We are going to take questions at the end of Dr. Spaderna's talk. And we have somebody watching the chat. So if you have questions online, make sure you put them in the chat. So today we have Dr. Max Spaderna, who is a faculty member in the Department of Psychiatry, for those of you not from the Department of Psychiatry, in the Division of Addiction Research and Treatment, and also a member of the Division of Community Psychiatry. Dr. Spaderna completed his BA in History at the University of Massachusetts Amherst in 2006, his medical degree at Boston University School of Medicine in 2010, and his adult psychiatry residency at Yale University in 2014. Following a 3-year run as adjunct faculty at Vanderbilt, working in a crisis stabilization center in Nashville, Tennessee, he came to Baltimore and joined our faculty in 2017, where he has been involved in a variety of clinical programs, including the Fayette Continuous Care Team, in the Division of Community Psychiatry, Psych Emergency Services, and the Addiction Treatment Center at our 1001 West Pratt location. Since 2020, Dr. Spaderna has spent increasing time and energy in the Division of Addiction Research and Treatment, assisting in the development and evolution of psychiatric care for individuals with SUD. He is currently a psychiatrist for the Health and Recovery Practice, which we refer to as HARP, a clinic formed from a partnership with the University of Maryland's Institute of Human Virology, our FPI faculty physicians, and the Department of Psychiatry that co-locates substance use treatment, physical health, mental health, and infectious disease care for patients with substance use disorders. It's unique. It's probably one of the kind in the state, very successful. I just might add that the program has reduced ER visits in that population by 95%. So really great program. He provides opioid use disorder treatment by telemedicine to patients at the detention center located in Queen Anne's County, Maryland. So Max is all over the place. Dr. Spaderna has established himself as a researcher in opioid use disorder and was actively involved in the LOOP study, a long-term outcome of opiate using persons, and the RISE clinic patch study focusing on transgender and gender minority individuals with substance use disorder. He recently completed two studies on which he was PI, a CARES grant, and the Community Engagement Research Grant, as well as he continues as co-PI on 2 other major grants involving SUD, substance use disorder, and HIV, and an R01 Bringing Health Home grant. Additional interests of Dr. Spaderna include suicide risk and intentional opioid overdose. So please join me in welcoming Dr. Max Spaderna as he presents suicide and overdose risk in opiate use disorder.
Thank you, Jill, for that really kind introduction. Can you all hear me all right? Should I project more? So thank you so much for being here today. I'm going to talk about suicide and overdose risk in opioid use disorder. And I want to start with this slide. And this is a slide that you've probably all seen before, but this shows the deaths from opioid overdose in the United States. And you can see that it's been divided into 3 waves. So the first wave or overdose deaths were caused by prescription opioid overdoses. And these were the result of prescription patterns where these became more available in the community and became substances that people abused. And then starting in the 2000s, this was replaced by heroin as people migrated to that, and the deaths increased from that. And then by 2013, we saw the introduction of synthetic opioids like fentanyl. And afterwards, you can see that the number of overdose deaths exponentially increased. Now, at the same time as we are experiencing this opioid epidemic, we're also seeing a suicide crisis. This shows the rise in the suicide rate in the United States from 2002 to 2022. Now, in the 1980s and the 1990s, we're actually doing pretty well. The suicide rate was actually declining in the United States. So by 1999, the rate was down to 10.5 per 100,000. And by 2002, it went up a little to 10.9 per 100,000. But over the next 20 years, the rate increased. So by 2022, the rate increased to 14.2. Now you can note a few things. Besides the increase, you can also see that there's a gender divide, that males are more likely to complete suicide than females by a 4-to-1 ratio. Now, we have these two crises, and are these two crises linked in some way? Before we discuss that, though, I want to just explain what we mean when we're looking at suicide risk. So suicide risk is two things. We're looking at suicidal thoughts, and we're looking at suicidal behavior. Now, why is this the way that we look at suicide risk? Well, the reason is because we don't have anything else, right? We don't have blood tests. We don't have imaging studies. This is the best way that we do this. Now, it is imperfect, but this is still the gold standard by which we assess suicide risk. There are many different ways that we can think about the risk factors for suicide risk in opioid use disorder. So you can look at it from the risk factors from the biological standpoint, the psychiatric standpoints, thinking about the overlay of social risk and overdose risk. Now, this diagram shows how we think about the neurobiology of opioid use. So what happens is that you have someone that they start using opioids, they get an intoxication, a euphoria, and this causes people to use again, to binge, to achieve that same euphoric effect. But what this does is that this leads to a countervailing effect of dysphoria, a negative affect, a withdrawal, and that this negative affect starts to worsen with chronic use. And this leads people to have a preoccupation and an anticipation for using substances. And so what happens is that the use of opioids shifts from trying to achieve this euphoria to trying to ward off this negative affect, which looks a lot like depression. Now, this is from a systematic review and meta-analysis, and what this shows are the prevalences of psychiatric illnesses in the opioid use disorder population compared with the general population. And you can see here that in the OUD population, the rates of psychiatric illness are much higher. So people with OUD are 18 times more likely to meet criteria for depression, over 7 times more likely to meet criteria for anxiety, 9 times more likely for PTSD, 7 times more likely for panic disorder, 8 times more likely for bipolar disorder, 9 times more likely for borderline personality disorder. So these are all diagnoses that we know are associated with increasing the risk for suicide. Now, this shows the different ways that opioid use can be impacted on the individual, the interpersonal, and the community and the social level. And when we think about society-level factors, it's important to remember that there is a socioeconomic drift that is associated with opioid use disorder. Now, when we think about this, it's good to keep in mind research that was done by economist Angus Deaton, who I believe is at Princeton. And he had this hypothesis called the deaths from despair. What he noticed was that between 1999 and 2015, during macroeconomic slumps, every percentage point increase in the unemployment rate saw a 3.6% rise in opioid death rates and emergency visits. And the fall in the employment rate resulted in lower life satisfaction and higher drug use among the population. Now, this explanation was used to explain the decrease in life expectancy among white working class Americans. But you can think about the way that social factors impact in many different ways. So opioid use disorder is associated with social stigma, and this can prevent people from getting treatment. Also, many times people with opioid use disorder lack insurance. This is a big issue in places like where I used to work in Tennessee, where they did not expand Medicaid, and might be a problem if there are cuts to Medicaid. They are more likely to be incarcerated, which not only increases social stigma, but also increases their risk of overdose, because people who are incarcerated and released into the community are at much greater risk for overdosing. It also has worse negative effects for minoritized and marginalized populations. Now, the rates of substance use are not greater, but the negative consequences are, especially for incarceration and criminalization. Now, when we think about the overdose risk, it's important to think about the supply of opioids. Now, what this shows is the number of pills containing fentanyl that was seized by law enforcement from 27 to 2023. And what you can notice here is that the increase in the number of seized pills is exponential. Now, at this point, I think it's safe to say that there is no more heroin on the street. At least I don't see it. It's all fentanyl. We know that fentanyl is many times more potent. It is much more lethal in overdose. But a question to ask is, well, does this increasingly lethal opioid that people have access to with opioid use disorder, does this impact and influence one's suicide risk? So this was an Australian study from 2017. This was retrospective data. And what they were interested in was a retrospective review of looking at people who had completed suicide and what their occupations were. And they found two things that were very interesting. One is that if you had an occupation where you had access to a lethal means of dying, you were more likely to complete suicide by that means. So if you had an occupation where you had easy access to firearms, you were more likely to complete suicide by that means. Or if you had an occupation where you had easy access to carbon monoxide, you were more likely to die by that means. The second thing that they showed here is that people who had occupations where they had access to lethal means were more likely to complete suicide, period. And what you can see here is that there's a gender divide. So males were 1.35 times more likely than females, or more, rather for males, they were 1.35 times more likely to complete suicide if they had an occupation with access to lethal means than those with access to non-lethal means. But for females, it was 2.5 times more likely. So for females with occupations with access to lethal means, they were 2.5 times more likely to complete suicide. Now, we kind of have some of this information, but it still doesn't tell us what people are thinking. So one way that we can look at it is asking people who have overdosed, what was their intent beforehand? Because it could be that people are just accidentally overdosing and that the two are not necessarily connected. So this was a study that was done in 2019, and they interviewed patients with OUD who were seeking treatment at an inpatient unit. So what they found was that their mean lifetime number of overdoses was 5.3. And as you can see here, that about 41.5% did not want to die. And again, what they were doing here is they're rating intent from 0 to 10 on a sort of a Likert scale. So 10 was absolutely wanted to die, 0 was no intent. That meant about 58.5, or about 3 out of 5 had some intent to die. Additionally, about 36% reported a strong desire to die, 21% reported definitely wanting to die. But you see here that there's this in between of people who are 2s, 4s, 6s, this ambiguity about wanting to die. So if you say that your intent is a 5 out of 10 before your last overdose, does that mean that that was a suicide attempt? So this is the challenge with trying to find this out. It's very difficult to find out whether overdoses are suicide attempts because unless you have a suicide note, we don't know. And it's difficult because people have varying levels of suicidal intent. So one way we can look at this is actually trying to prospectively assess suicide risk in the opioid use disorder population, which had not been done before and which had led to this publication that was just published in March of this year. And so this was using data from Sarah Catacuzzi and Alana Rosenthal's cohort. And we had three questions. First, what is the rate of suicide risk in the opioid use disorder population over a 1-year period? 2, does the detection of suicide risk differ by screening tool? And 3, which characteristics are associated with suicide risk in opioid use disorder? To answer this, we use the long-term outcomes of opioid using persons cohort, or LOOP. LOOP was a 2-year prospective natural history cohort of individuals with opioid use disorder. They're followed every 6 months. They're in the community, about 200 people who are enrolled. The people were enrolled from 3 treatment sites. One, an urban syringe service buprenorphine treatment program in DC called HIPS. The urban opioid treatment program at the addiction treatment program, which is at HARP, which I work, and then a rural mobile buprenorphine treatment program in Caroline County, Maryland. So individuals are at least 18 years old and met criteria for opioid use disorder within the past 3 years. This is how we detected suicide risk with 3 screening tools. The 9th item of the patient health questionnaire, or the PHQ-9, the suicide domain of the cross-cutting measure, and the Ask Suicide Questions questionnaire, or ASK. Now, this is the patient health questionnaire, PHQ-9, so you probably are familiar with this, but this basically looks at the 9 items of major depressive disorder in the DSM-5, and it rates it by frequency. So it rates each one from 0, which means someone is not experiencing it at all, to 3, which means that someone is experiencing that every day. The 9th item asks about suicide risk in this way. Over the past 2 weeks, how often have you been bothered by thoughts that you would rather be dead or thoughts of hurting yourself in some way? Now, this is not a screening tool that was made for suicide risk, but it has been used to assess for it. And you can notice that the question asks about both passive and active suicidal thoughts or intent. Now, it has been used to detect suicide risk in the substance use population, but it's been shown to have some problems. So in one study, 46% of respondents with substance use disorders that reported not at all to the 9th item attempted suicide within 90 days. So it's an imperfect measure. Now, this is the DSM-5 cross-cutting measure. This is one of the emerging measures from the American Psychiatric Association used for further research and clinical evaluation. It was developed to be administered at the initial patient interview and to monitor treatment progress. And what it does is it asks questions within specific domains like depression, mania, psychosis, anxiety, etc. There's a domain on suicide. Here's the 11th. The one that we used was the 12th one, so we have it as the 12th item. But you can see that the question here is asking during the past 2 weeks, how much have you been bothered by thoughts of actually hurting yourself? So that's how they assess suicide risk. Now, if you compare this with the 9th item of PHQ-9, you'll notice that it's only asking about intent to harm oneself, but it doesn't ask about passive suicidality. It also has not really been studied before, and it's never been used in the opioid use disorder population. Now, this is the Ask Suicide Screening Questions questionnaire. It was a tool that was designed specifically to assess suicide risk. It's composed of 5 items. The first 4 items look at suicidal thoughts, and the first 3, and then the 4th is about a history of suicide attempts. Now, if you answer yes to any of the 4, you are screened as someone with suicide risk. And this prompts a fifth question, which asks, are you having thoughts of killing yourself right now? And if you answer yes to that fifth item, you are deemed an acute suicide risk. So this has been validated in several different populations, including in a substance use clinic, but it's never been studied in opioid use disorder until now. Now, if one study that used the ask in a medical hospitalized situation or population, they found that about 15.6% screen positive by the ask, which is pretty high. But these are people in a medical hospital. There's a lot of stress, but that is how high it has been. But it's never been studied in a community population of opioid use disorder. So we had 121 people that we included in this investigation, and you can see that it's predominantly male. 4/5 are Black, 44% were unstably housed, 15% had no income. This is a population that is very representative of the patients that I treat, and I'm sure that many of you treat. I'd also note that about 2/5 report a history of physical or sexual abuse before the age of 17, and 16% report being physically abused by someone at that point. Now, in terms of their opioid use disorder, their scores put them into the mild to moderate range, and you can see that it declined over a year. About 17 to 18% were using opioids daily. Most were prescribed medications for opioid use disorder. 2/3 had urine drug screens positive for opioids. Almost half had urine drug screens positive for cocaine. The hazardous alcohol use actually declined over time, and you can see that 8.3% reported a history of intentional overdose, which was the only time point that we screened for, but that's pretty high. In terms of their psychiatric comorbidities, that you can see that over time people were prescribed psychiatric medication. So by the end of the 12 months, about 3/5 were on psychiatric medications. The PHQ-9 score put them into the sort of mild depression range, so right at the borderline. About 16% met criteria for psychosis by the cross-cutting measure. You can see that the rates of mania were very high, did decline over time, but I will caution that this is probably an overestimate. It's well known, and probably from people's clinical experiences is correct, that people with opioid use disorder are often overdiagnosed with mania. Now, the SF-36 is a quality of life, and this looked at the general health score. In the OUD population in studies, this ranges from 39 to 55. Higher scores represent better quality of life. So in this cohort, the quality of life for general health was actually a little bit better than on average. And about 2/3 met criteria for poor sleep by the Pittsburgh Sleep Quality Index. Now you can see these are the rates of suicide risk by each screening tool. Now, what you notice is that the ask, which is in the blue, that there were 7.5 times more people identified with suicide risk in the cross-cutting measure. In fact, there were 3 times more people identified for suicide or assessed or identified with suicide risk by the PHQ-9 than the cross-cutting. So the cross-cutting measure at each time point identified the fewest number of people with suicide risk. You can also note that the rates of suicide risk did not decline significantly over time. Now, one question that you might have is, okay, so the ask identified the most people with suicide risk. However, if you answer yes to any of the questions in the ask, then you have assessed with suicide risk. Well, if you answer yes to question 4 about a history of suicide attempts, you will always screen positive for suicide risk. Correct? And that's reasonable. So this is the breakdown of the individual responses. And you can see here that the blue is the 4th question asking about a history of suicide attempts. There are 2 things that I want to highlight. One is that no one answered yes to the 5th item about having active thoughts to harm oneself. So this is actually reassuring to us for 2 reasons. One, it means that our patients or individuals in the study did not want to actually take their lives. But also, when you're thinking about these screening tools, they're goal and the aim is to implement them in a primary care setting where you're seeing a lot of people. So if you have a screening tool where everyone is screening as an acute risk and needs an emergency evaluation for suicide risk, you can see how that could really gum up the works for a primary care practice. The second thing is that you can see that the rate of people who are answering yes to the fourth question about suicide attempts declined over time. So people were actually not consistent with that. But this allowed us to actually look and see what the risk factors were. And I'll show you what I mean. So these were the variables that were associated with suicide risk by our model. Before I go into these, I want to explain what this model actually shows because it's a little bit complicated, and I have to really thank Sim Kang at the NIH, who's a statistician who did this, because it's a very complicated model. So this is a generalized methods of moments model. And what it does is it looks at how a independent variable of interest that you have impacts an outcome at different time points. So this is what I mean. Let's take, for instance, meeting criteria for psychosis by the cross-cutting measure. You can see that that's significant. So the current time point means is that if you meet criteria for psychosis at day 0, how does that affect one's suicide risk at day 0? Or if you meet criteria for psychosis at month 6, how does that affect one's suicide risk at month 6? What the one time point lag says, all right, let's say you meet criteria for psychosis at day 0. Well, how does that affect suicide risk at month 6? Or if you meet criteria for psychosis at month 6, how does that affect suicide risk at month 12? And the 2 time point lag says, all right, if you meet criteria for psychosis at day 0, how does that affect suicide risk by month 12? So you're able to see how a variable affects suicide risk at different time points in different ways. So in terms of the ones that were collected at day 0, so only at one time point, you can see that intentional overdose history and female gender were the 2 that were associated with suicide risk. And this makes sense because in our study that females were much more likely to answer yes to the item 4. And this is also consistent with what we know that women are more likely to attempt suicide than males, though males are much more lethal in their attempts, so thus have a greater rate of suicide completion. And then when you look at the time-dependent ones, the ones that were checked at each time point, what you notice is that they were pretty much psychiatric symptoms that were associated with suicide risk, but not really substance use, except for one at one time point. Now, intentional overdose history, it's associated with suicide risk. But again, intentional overdose history, someone says that they tried to overdose, isn't that a suicide attempt? Of course they would be associated, right? So let's actually look at the data. So this shows in our study the 10 people who reported a history of intentional opioid overdose at day 0. And what this does is it shows the breakdown of those who answered yes to the 4th item about suicide attempts in blue, and those who answered no, which is in red. So what you notice is that at day 0, 90% answered yes to both. But there was one person, or 10%, that answered no to the 4th item. But you notice that over time that the number of people answering yes to the 4th item about suicide attempts declined. So not only are people with a history of intentional opioid overdose not identifying these as suicide attempts, but over time, fewer people are actually identifying these intentional overdoses as suicide attempts. So this is what we can say based on our data is that the rate of suicide risk is high. Now, if you remember that in a medically hospitalized population that that ASK identifies suicide risk as 16%, 15 to 16%, that in this community sample of OUD patients, it's pretty much double. Also, the detection of suicide risk varies greatly by screening tool. The ASK is identifying a lot more people with suicide risk than the cross-cutting measure. It's really something associated with psychiatric illness, but not substance use outcomes, and it's associated with intentional overdose. So now we ask the question, what about this intentional overdose, right? We have all this data that's showing that it's kind of like a suicide attempt, but it's somehow not. What's going on here? So this led me to investigate this further. And this is actually something that we hope to publish looking at this. But this was from a grant, and we had two questions, which is one, what is the proportion of intentional opioid overdose and opioid use disorder? And two, we wanted to compare those with and without a history of intentional opioid overdose on substance use, psychiatric, and overdose outcomes over 2 years to see if there were differences that identified them. Now, again, we used the loop cohort. In this investigation, we had 192 individuals, and we split up the groups into three based on whether they had an intentional overdose at or during their study or investigation, whether they had unintentional overdose at or during the study, or no overdose at or during the study. And they were assessed at 3 time points at day 0, month 12, and month 24. Now, how did we identify those with a history of intentional opioid overdose? By 2 ways. So at day 0, we asked people this question: have you ever intentionally overdosed on heroin or opioids as a way to kill yourself? The other is that with the ask, if someone answers yes to the 4th item, there's a sub-question that asks, well, how did you attempt suicide? So if anyone answered that they tried to end their life by overdosing on opioids or heroin, they were included in this. Now you see the breakdown, the diagram of how we came to this. So at day 0, there were 15 who reported a history of intentional overdose, 105 who reported a history of unintentional overdose, and 72 who reported a history of no overdose. Between day 0 and month 12, there were 4 people in the no overdose group that experienced an unintentional overdose. So they were included in the month 12 as the unintentional. And then from month 12 to month 24, there were an additional 4 people in the no overdose group that had an unintentional overdose. So by month 24, there were 15 in the intentional opioid overdose group, 113 in the unintentional overdose group, and 64 in the no overdose. So you can see just over time that there was attrition. There were fewer people who were in the study by month 24. And you can see the demographics. So again, a middle-aged population, predominantly male, predominantly Black, almost half, or 40 to 50%, were unstably housed. About 15 to 20% had no income. But here's what I want to note, that when you look at these 3 groups, they're similar except for 2 ways. One is that in the intentional opioid overdose group, there were about 3/4 of the group that reported a history of physical or sexual trauma before age 17, which was much higher than the other 2 groups. And you can also note that in the intentional OD group, that 2/3 reported a history of suicide attempts, which was much higher than the other groups. Though I will note that the other 2 groups had pretty high rates of suicide attempts. So again, highlighting the risk in this population. So these are the substance use outcomes, and you can see, just looking at the 3 groups, that there's nothing statistically significantly different between these groups, that their substance use outcomes are not identifying differences. Now, this is just more information. You can see that there were some differences. So you can see in the urine drug screen for opioids at day 0 that there were more people who had opioids in their urine drug screens in the unintentional group and the no overdose group than the intentional overdose group. You can also see that the OUD scores at day 0 month 12 were higher in the intentional overdose group. Now, why is this? Well, the OUD score, which uses the 11 symptoms of opioid use disorder by the DSM-5, looks at both objective and subjective symptoms of opioid use. And so it's reasonable that the people with intentional opioid overdose might be having more of a negative subjective effect from their opioid use. Now, these are the psychiatric symptoms, and what you notice is that at month 12 and month 24, that depression severity was increased in the intentional opioid overdose group than in the unintentional and no overdose group. And on month 12, that the anxiety was higher in the intentional opioid overdose group. Now, this looks at overdoses, and you can see that there is no difference between the intentional and unintentional in terms of overdose outcomes. But there are just some things I want to show. One, at day 0, that about 6 to 7 and about 5 overdoses in lifetime, which shows just what a high overdose risk this population has in general. And also within 12 months from day 0, month 12, and month 12 to month 24, there are high rates of overdoses that were occurring even within this year. So what do we know about intentional opioid overdose? So from our data, it's about 8% of individuals with opioid use disorder, which is quite high. And there's an intersection with suicide risk. Similar to suicide risk, what we're looking at is not an issue of substance use, but of depression severity. And it is associated with childhood trauma. So this led me to ask more questions and try to do more investigation. So this is a qualitative study that's funded through an ICTR grant. And what we did, or what we're doing right now, is doing 14 qualitative interviews, 7 people with a history of intentional overdose, and 7 with a history of unintentional opioid overdose. Interviewing the people, looking for differences in terms of their opioid use, their mood, what they think about mental health, et cetera. Transcribe that, do a thematic analysis, and then our goal is to create a screening tool that can identify those at risk for intentional overdose. And we plan to use this, what we develop as a screening tool, and receive feedback from stakeholders, those who have a history of intentional opioid overdose, and providers who treat patients with OUD to fine-tune the screening tool.
Also interested in the connection to psychiatric treatment, because as we see here, there is a high psychiatric burden in the opioid use disorder population. And so in the LOOP study, and even just now with my clinical work, if someone is in the study and they're identified as needing psychiatric care and they can't get in the community, they can be referred to me and receive psychiatric care through a telemedicine clinic. It's a low barrier clinic.
Now, in this, the people that have been referred to me, we are going to interview 15 people, 5 who referred to me but never saw me, 5 who referred to me, but it took them 6 months or more to actually get an intake appointment with me, and 5 who referred to me, got an intake, never saw me again. Again, we'll interview, we'll transcribe, we'll do a thematic analysis, and our goal is to use this information to find strategies that can improve linking OUD patients to psychiatric care that could be used for future studies. Now, I want to highlight some of the clinical work that I'm doing in this. Now, I am part of the Research Initiative in Infectious Diseases and Substance Use Clinic, or the RISE Clinic, and this was formed from the DC Partnership for HIV/AIDS and Progress, or PFAP, which was through the NIH Office of AIDS Research. And it has, the goals of looking at the clinical and research into the intersection of how infectious disease, substance use, and marginalized populations all intersect. It's at 3 sites, HIPS, HARP at the Addiction Treatment Program, and the Mobile Telemedicine Clinic in Caroline County. Now, HIPS is a harm reduction clinic in Washington, D.C. It provides mental health and substance use treatment as well as social work to its populations, and I've been seeing patients there since 2020. I also see patients through Baltimore Safe Haven. So this is a drop-in center, and it's really aimed at the LGBTQI population. They are able to provide housing support, mental health treatment, and harm reduction services. And I've been seeing patients since 2023. I actually just want to highlight this. This is predominantly a transgender population, which has a high prevalence of psychiatric illness. And it's been hard for people to get psychiatric treatment. So I provide the psychiatric treatment. I also do the evaluations for gender affirming surgeries. This is a really exciting population to work with, and I've been very happy that I've had the opportunity to do that.
So these are the number of patients that I've treated from 2020 to 2025, a total of 160, about 113 in HIPS, 41 in Baltimore Safe Haven, about 6 in other sites.
And this shows a patient's visits by month and year, and you can see that over time, we've been seeing a lot of patients. So this busy clinic, I just actually had my clinic this morning. I think I saw 5 or 6 people. Really interesting to work with this. Again, we're able to establish and to give psychiatric care to populations that it's hard to engage and to get treatment for. So I just want to acknowledge the Rise Clinic. This is a picture of them for a few reasons. I would not be able to do the clinical or research work that I am doing now without their help. It's a very difficult population to work with because people have difficulty getting in touch with people, coming to clinic, having phones. They do a lot with outreach, being open, working with people. And it really requires a major infrastructure to be able to achieve this clinical and research work. And I want to acknowledge these 2 people, Sarah Catacuzzi and Alana Rosenthal, for 2 reasons. The reason that I'm actually doing this work is because of them. In 2020, they agreed to fund 10% of my time, and I didn't even know it at the time. But thankfully, they decided to do that. And it's through them that I'm able to do this work. And the work that they do is really important because, again, this is a patient population that has a high psychiatric burden, but is not that well studied. And they're really working with this population and doing studies that can benefit them. It is not easy work. I hope that they are able to continue to do this. So that's everything, and I will leave the rest of the time for questions that you all might have. Can you, I probably go to the mic, I guess.
Thank you, Max. It was a really interesting talk. I had a really basic question, actually, in thinking about how well we are able to assess true suicidal intent through a question. And just thinking about when we're asking people to fill out forms, they may be in various states of intoxication or have a recent stress that colors how they respond to a question. I wonder if you could just talk about the struggle of getting accurate data through questions on intent. And it does seem like a lot of this work is on help-seeking populations as well. So thinking about like how to tap into suicidal intent in non-help-seeking populations.
That's a great question. And you're right, it is very challenging because it's all from self-report. So if someone is actually suicidal and says, I'm not, well, there's no way that we can figure that out. And again, it has a lot of limitations, but this is the best that we have at this point, and that's why we rely on it. I think the other thing that I notice is, because you were mentioning if someone is in various levels of intoxication, we see this all the time in the PES, where then people are suicidal because of that. But I also see the opposite, where people don't feel comfortable talking to someone that you just met, and so they're actually experiencing this and they don't actually say that. I think that the screening tools are imperfect, but they're the best that we have. But I think where they're helpful is that it can get people identified for psychiatric care who might be missing through the cracks. And I think if you're able to establish a rapport with someone in substance use clinics, that people will be more willing to open up and say, you know, maybe I do need help, maybe I want that. I think that there's in this population a resistance to that, and it can take some time. So there's definitely a limitation with this. But I think that even with those limitations, just the high rates of suicide risk in this population has not been really appreciated. and shows that we really need to extend psychiatric treatment and make sure that it's available. Yes.
That's fair enough.
Hi.
I'm curious as it relates to severity of opioid withdrawal. By, you say, that cap. Oh, sorry. I can repeat the question.
That's all right.
All right. Well, anyway, in your research, have you seen whether the severity of opioid withdrawal at all confers an increased risk of suicide in patients?
That's a great question. So in my research, not clinically, yes. And for anyone who's been in the PES, as I'm sure all of you have, you often see this, that people are in withdrawal and they report being suicidal. Now, there was actually case series that I wrote. It was first author with Dr. Weintraub and with Melanie Bennett. And it showed that for individuals who presented to the emergency department suicidal, and you gave them buprenorphine to treat their opioid that withdrawal symptoms, and provided for them to have after leaving the emergency department, that this magically treated their suicidal ideation. Now, is it because it magically treated the suicidal ideation and buprenorphine has anti-suicidal properties? Well, maybe, but it's probably that people are in crisis. They don't know how best to get help, and they're going there and saying, I need help. And how do you get help the quickest? I want to kill myself. So what that shows is that it's important to identify and connect people to OUD treatment. But with that, it's not enough to treat that and say we're treating suicide risk. And that's, I think, the big take home that I would take is that when we're thinking about suicide risk in the OUD population, we can't just chalk it up to substance use, that there is an increased psychiatric burden separate from the substance use. As you can see, it's not substance use that's differentiating these groups. It's something else. So we really need to identify these people and get them in treatment or connect them. Any other questions? Yes. Yes. Oh, yeah, sorry. Sarah asked about the impact of trauma in this population and how it impacts suicidality. I will say that as a psychiatrist in community addiction, most of what I'm dealing with is trauma, childhood trauma, sexual trauma, awful trauma. That's really what I think I'm treating. And there is a massive amount of trauma in this population. It, in my opinion, absolutely has a huge risk for worsening psychiatric pathology, for suicidality, and it really needs to be investigated and studied. We can go into a more esoteric conversation about why it is, as psychiatrists, that we tend not to think about trauma as much and try to call it bipolar disorder or borderline personality disorder. I'm not going to go there. But I will say that if I am able to continue this research, which is a big if for a variety of reasons, that's one of the lanes I would want to go down because it's so important and it's so under-investigated. Yes, Aaron Greenblatt.
Trying to think how to articulate this question, but it seems that there's an overlap between risky and impulsive behavior and intentional suicidal behavior. And you're really getting at kind of identifying people who are at risk for intentionally and consciously being able to understand that they're trying to end their life, if I understand you right. But the majority of people who have overdoses we tracked had things that they described as unintentional overdoses. In practice, I see that people who are in active chaotic substance use kind of don't care if they have an overdose. And so it wouldn't necessarily fit into this, I would like to die. Now it's more like I want to escape and I want to get high. So I guess one part of the question is, how do we is there a way to suss that out, or is this kind of one of the limitations of having a questionnaire-based study? And the other question is, I don't know too much about suicidality, but are there other risky behaviors, say reckless driving, that are also associated with suicidal risk? Like, if you look at the risk of car accidents and suicidality, is there an association, or other risky non-substance associated behaviors that might be associated just with kind of like not caring about what your behavior is?
So to the second question, I don't know the research off the top of my head. Just my gestalt would be that there is probably an association. I don't know how well that's been investigated. If you have access though to more lethal means, you're more likely to complete suicide, period, as the data showed, and this has been shown in many different areas. But you bring up a good point about intentional opioid overdose, which the data that we have in some previous data shows, which is that it's really hard to identify the intent, because it's not, I definitely want to die, I definitely don't. It's this middle ground. You're right. It's this, I don't care, so we'll put ourselves in this risky situation. Now, the qualitative data that I've done, it's not published. I just did an initial thematic analysis. Found a few very interesting things. And again, the qualitative data I interviewed 7 patients with a history of intentional opioid overdose, 7 with a history of unintentional opioid overdose. What I found very interesting was that the intent was in the intentional opioid overdose was often ambiguous, but there was definitely a planning that people would say, I got the really lethal stuff. It was cold that night. It was snowing. I locked the dogs in my house so they wouldn't rescue me. And I shot up, and I was not expecting to wake up in the morning, which was a little bit surprising. But this ambiguous intent is also interesting because for the unintentional opioid overdose group, and they were saying, well, I wasn't trying to harm myself, but they would say, well, I really wanted to get high. And if, people would say this often, if there was someone who overdosed and died, they would seek out the dealer because they knew they had the good stuff. So it wasn't so much that they wanted to die, but you're putting yourself in a reckless situation saying, I don't care. So you wouldn't call that, I guess, suicidal intent, but you can see how there is that sort of Venn diagram of the intents. And maybe that's explaining this ambiguity, because this sort of people don't know how to articulate that, or maybe understand that, and that's probably what you're seeing. Our hope is that with the screening tool, we could actually at least identify that, and that's the reason we want to do the screening tool, because it's not a typical suicide attempt. It requires its own screening tool to try to identify these people. And again, I think the utility besides identifying people is that we can connect them to psychiatric treatment, because that's really what's going on. That's also with the qualitative data. The people were different by depression severity. Not published, it's just the thematic analysis that I've done. We have to do more work on it, but that's what the data that I have in a preliminary state is showing. Any other? Yes, Peter.
A great talk, Max.
Thank you.
I really like the data from the time lag model. Have you thought about inverting it and looking specifically for factors that predict subsequent reduction in suicidality to try to find factors that might promote resilience that we could then leverage to improve outcomes?
I haven't, but that's actually a great idea. Something to think about. It would be helpful that with this data that we could actually identify interventions that could decrease suicide risk and intentional opioid overdose. And maybe if we did an investigation or figured out a way to do that, we could identify that, but it's a great point. Yeah, Sonia.
Inherent overlap between trauma and then substance use and then suicide risk. But it feels like when we do a risk assessment, what we usually talk about is modifiable risk factors and so substance use and so the point of conversation. I guess is there like an alternative that is being proposed in addition to like getting someone psychiatric care and maybe getting them connected to patient basis? I feel like there's also this kind of major thing, which is maybe to get connected to maybe substance use treatment.
Sorry. It feels like the central thesis, though, is that the most modifiable risk factor for a risk assessment for someone who has active substance use is to get them substance use treatment. And so how effective is psychiatric care if someone is continuing to do the most modifiable and maybe the most risky thing that is contributing to their increased suicidality or suicide risk?
Yeah, that's a great question. So, and if I'm hearing correctly, especially in the emergency department, we see this often where people express suicidal ideation, their modifiable risk factors, substance use treatment, and we get them in there. The substance use places that we do get people in should have a connection to psychiatric treatment, but it doesn't modify their suicide risk. I think what the data shows, and it shouldn't be too shocking, is that substance use treatment places really should integrate psychiatric care because there's high rates of psychiatric care, high rates of suicide risk. And substance use treatment is definitely important, but it's not going to modify suicide risk. My hope with some of the investigations that I'm doing is we can figure out ways that we can connect people and retain people in psychiatric care, identify them, so we can modify those risk factors. So again, substance use treatment is important, but we need to think about the psychiatric because we can't just say, well, if they stop using or their use is under control, then they're not going to be suicidal. The data I have does not support that. Yeah.
I guess the question is, when we talk about substance use treatment,
Mhm.
are we just talking about like MAT or just like purely a most symptomatic treatment of substance use? I guess maybe we're privileged here in that a lot of our substance use treatment does have co-occurring psychiatric treatment on some level of someone is seeing a provider, might end up on some psychiatric medications. But is that kind of the differentiation?
So I'm sorry, I might be a little bit, so you're talking about getting people onto MOUD, like medications for opioid use disorder, instead of symptomatic treatment?
When we talk about substance use treatment,
Yeah.
right? What are we talking about?
So what I'm talking about are treating the substance use, which the gold standards are medication for opioid use disorder. That's separate from the psychiatric, at least the way I'm differentiating it. But what I would argue is that they need to be integrated. The nice thing about something like HARP, where Dr. Greenblatt, Dr. Catacuzzi, and I work, is that we can co-locate primary care, psychiatric care, infectious disease care. One-stop shopping for this patient population who's hard to engage in treatment. And so if someone is identified as needing psychiatric care, they can just be referred to see me or Dr. Rompershot. Models like that are, I think, needed to try to mitigate suicide risk and also treat psychiatric illness. If the treatment is split, it's very often difficult for people to come to different appointments. So I would argue that when we're thinking about substance use treatment, we think about whether we can offer people psychiatric treatment for those who need it. Now, not everyone who requires substance use treatment needs psychiatric treatment. My work in the jails at Queen Anne's County is really interesting because I rarely see people that need psychiatric treatment. I'm just prescribing buprenorphine, but I often see people there is like, yeah, I use 8 to 10 bags of fentanyl a day. I'm sick of this. I want to be on buprenorphine. Any depression? No. Ever been seen a psychiatrist? No. Ever been hospitalized? No. They just really have substance use disorder treatment and they need it. So not everyone with substance use disorder treatment has a psychiatric illness, but there are a lot of people who do, and they need to be identified and receive treatment. Yes.
So Max can answer more questions one-on-one up front, so again.
Nicely done.
Thank you.